All right, hello everyone. Can everyone hear me okay? And yes in the chat if you can hear. Yeah, oh, okay, great. All right, so welcome. Thanks everyone for joining us. Let's go ahead and get started and we'll just do our normal roll call. If you could put your name and location down in the chat, or you are welcome to unmute yourself. If you are joining us by phone only, that's great too. We just love to see who's here. Welcome, one and all. Hi, Cindy and Jill, Linda, Rocio, Natalie, Kara. Welcome. We appreciate all of you for taking the time. And who's joining us just by phone today? You can press *6 to unmute yourself if there's not just a simple mute button. All right. Well, looks like we also got Irma from Sunrise and Katie from Sunrise. And on our side today, it's Amy, of course, and Elsa, and then Lori Workman is here as well.
Morning!
Yes, you can see the corner of her face, but that's who that is. That's Lori. All right. Well, we will go ahead and get rolling here. We'll get through our announcements, and then today our kind of main focus will be smoking cessation. So I'll let Elsa go ahead and jump in on the announcements. And of course, as always, if you have any questions, anything you want to stop, just chime up and let us know, and we are here. All right. So I have some announcements of upcoming dates for both training opportunities, webinars, a little more information about the date of our annual meeting that will be in the spring. And this will all be sent out, of course, in our follow-up email with the notes from today's meeting, but I just wanted to let you all know out loud as well. So next month's monthly call will be Tuesday, March 5th, same time, 12 to 1. That call will be focused a little more about the information about the patient navigator training or patient navigator registry that CDPAG, the health department, is leading. I know there's been a lot of questions about that. There's still the intent to have navigators get on that registry, but I know there's been a lot of questions that are coming up. So we'll have more to come about the training opportunities and the registry itself. So stay tuned and join us next month, and we'll have some outside perspective as well. Then upcoming webinars, Amy has gotten a whole slew of those lined up with different topic areas. So our next one will be February 19th at 12 p.m. and that one's focused on reading and understanding endoscopy and pathology reports, and Dr. Jennifer Kolb from the university will be our speaker for that one. She has a lot of knowledge about just what you would want to focus on when you're looking over those reports as it relates to navigators and the work that's done with the program. And then we also have on February 25th at 11 a.m. there's a webinar that's you've been diagnosed with cancer, now what? Because screening is the main focus, but we want to make sure that the patients get their care if there is a diagnosis. So some training around that. And then our other training webinar coming up is we have another CCSP 101, so on February 26th from 12 to 2 p.m. So if you missed our first one,
which was a month or two ago, and you have anyone new at your clinic system who's only been working on the program for a little while, or anyone who needs a refresher course, just about the basics of navigating through CCSP and all of the program components. And then finally, our last webinar lined up at this point, but there might be more coming as well, is we have an overview and the basics of family history screening, led by Dr. Katie Lemus from Grand Junction, who's a genetic counselor that we've been partnering with on the family history pilot work. So it's a great opportunity to learn more about the screening tool and those processes for getting patients screened for familial and genetic predispositions to cancer. And so that one is March 21st from 12 to 1. And then finally, our annual meeting for CCSP. Amie has sent out a save the date and a calendar invite. We have not yet sent out the registration info yet. We're just finalizing some logistics, but it will be in the Denver metro area, and it is an all-day event. That's Friday, April 26th. Not that soon, a little bit more time, and hopefully no snow at that point. But we will have travel reimbursement for mileage if you're just driving in for the day, or if you're coming from a farther distance, travel reimbursement for lodging and per diem for food as well. And so stay tuned for more about that, but it will be a opportunity to connect with other clinics and also hear more about the pilot initiatives, and then some other dedicated focus and opportunities to have some workshop type discussions as well. So we're really excited and have the opportunity to hear from some other organizations involved in some other grant programming as well on that date. And then I want to turn it over to Amie quickly to tell us a little bit about some opportunities coming up from the Patient Navigator Training Collaborative.
Thank you much. So this PNTC, that's something that if you've been with us a while, you've heard about. We've talked about different things that they've done before, and they've been working really well with us and helping us out with some things. So they have something coming up that is a training focused on care coordination. They will have an online version as well as an in-person version that will take place in Lafayette, Colorado. And basically, it's something kind of different from what you would normally expect. It's not just a typical training. They've actually been partnering with ECHO, Colorado, and they are working on a study to evaluate how their trainings and the work they do improve team-based care and coordination skills. And it just seems like a very interesting opportunity, something different. I will send out more in-depth information because I don't want to read at you this whole wonderful flyer that they have. But this will be occurring throughout March. The online version is March 1st to the 29th, and then they also have the ECHO sessions as well, which will be through March to the beginning of April, or the in-person training is coming up soon. That's in February 11th. So all of that information will be in our follow-up if you have some interest in that.
Great. So I want to give Lori a chance to see if we have any updates from the billing and finance side of CCSP.
Not really, but just keep sending in those invoices, please, no matter what. Even if you've reached your allocation, send them in.
And those barrier reduction requests as well, right? And along those lines, just a monthly reminder that the next evaluation report, so the January evaluation report, is due on February 10th. Well, and I believe that's on a weekend this week, or this time, so February 11th will be our due date this month. And so if you have any questions or concerns about the evaluation, as always, please reach out to me through email or call, and I'm happy to talk with you and provide any support so that we're getting the most accurate data possible. And I have been reaching out to a few clinic systems just to clarify some numbers from the last couple months. And I did say before that I was going to share some mid-year data report yet today, but we have not gotten all of those numbers fleshed out quite yet. So we will have some more of a data summary coming to you probably in the next month's call. So thank you very much, and we look forward to sharing that information about how all your hard work is going on. And then I'll turn it over to Amy to get us going on that. But she may also, she'll have another activity for us at the end of the call as well.
All right, so as I had mentioned, our focus this month is going to be on smoking cessation. Let me go ahead and pull this up here. Is everyone able to see the PowerPoint screen?
And while we're getting that pulled up,
Perfect.
please let us know if you have any questions throughout this PowerPoint about either the PowerPoint or anything we've mentioned in the announcements so far. So feel free to send those in a chat or take yourself off mute and interrupt us.
So yeah, we really have been trying to focus around things that, of course, are related to cancer and related to health, but not necessarily specifically, colorectal screening or cancer screening, and just trying to really touch on subjects that focus on the bigger picture. So with that, we have smoking cessation, because of course that truly ties into everything when it comes to our health is the issue of tobacco and smoking. To clarify, I am a trained tobacco cessation specialist. I have been trained through the Mayo Clinic, and so all of the information that you see up on this slide, certain statistics, facts, things like that, are almost everything will come from the Mayo Clinic and the training that I received there. And then, of course, different areas will be noted otherwise. But just to clarify that, if you see something, that is where it is coming from. I promise I didn't make stuff up. So hopping right in, why do we care? I don't need to explain this to any of you, but just if you're a nerd like me and you like seeing the numbers, here they are. Most of this will focus on the cigarettes themselves, because of course that's always been kind of the biggest issue within that area of tobacco and nicotine. Up to 60 carcinogens in your regular cigarette. There's almost 30 in smokeless tobacco, so chew and snuff. Even if you use that, you're still not getting away from these substances that cause harm. A whole slew of health and cancer issues that come from smoking. Again, I know I'm not telling you anything new. And even if you didn't care about health, $300 billion a year in the US due to death and disability from cigarette use. Focusing on Colorado and looking a little closer to home. This image here on the map, you will see it kind of broken out by county for smoking rates. The darker the color would indicate the higher the smoking rate. Our average in this state is 15 to 15.5 for adult smokers. Vaping use is about 5%. I think it's gone up a little bit with the newest data that's come out, but it's still around there. And then looking at smokeless tobacco, we have 7.2%. And that's focused specifically on males. They are the primary users. So when you see those numbers, it is typically focusing on the male population. But on a positive note, 68% of current smokers have attempted to quit in the last year. So it's something they care about. It's something that they're working on. It's just a battle. When you are talking to your patients, the good news is the majority of them probably are going to have that on their radar, and they are going to have it in their mind that they do want to quit. And I just put this in here for my number lovers. If you prefer the data in this form, this is just matching that map that we just saw on the other scale, but it helps you see kind of more specific by county. If you want to just look specifically at your area, it'll give you a little extra info there. So smoking itself, nicotine, of course, is really at the heart of it. That's the substance that causes addiction. That's what keeps a person continuing to smoke, regardless of whether or not they even like it. That's what gets them hooked. And really, we have changed looking at smoking and looking at addiction as its own kind of disease. It has its own etiology, its own physiology, symptomology, all of that. It's really starting to have its own, we look at it as a disease and not just a bad habit or something like that, which is good because then it really helps us to focus more on the medical side and the treatment side and getting the resources. So just a quick snapshot, what happens when we have a cigarette? It's reaching the brain in 7 to 10 seconds. So it's a very quick effect. It's really helping people that want that immediate satisfaction. That's what the cigarette does. It's getting in the brain, it's hitting those receptors, which are acetylcholine receptors. We don't actually have nicotine receptors. Everything you read, everything will say those nicotinic receptors, but they're not actually nicotine, they're acetylcholine. And again, if you're a nerd like me, that's really interesting. So a few seconds later, you start to get that euphoric effect because then dopamine is released, which is our neurotransmitter that's like the happy drug of our body. So that's released, we get the feel-good feeling from the hit we just took, and with a regular smoker, you have control. You can smoke a whole cigarette, you can smoke 2, you can smoke a half. You have that control to get the exact effect that you want. So that's that self-titration. They can go all day long and they can get the exact feeling they want depending on how much they smoke. There is a link down here. I'm not going to play the video, but I do recommend, I will send out this PowerPoint to just check it out. It's only 3.5 minutes long, but it really kind of paints an awesome picture of what's going on in the brain itself when someone is smoking. So just a fun little info video to check out at some point. So now I'm going to switch into the actual kind of cessation information. Really understanding the things that you can do to work with your patients to kind of help them through this difficult challenge. The first part would be just a general assessment. And a lot of this stuff, I know there's a lot of clinics that do, you know, every visit, every time you go over, I think it's the 5 A's or something similar to that to assess where the patient is at. So that would be something that is a great example of what to do. You really want to look at where they're at, their smoking behaviors. So how many packs a day, what are your triggers? There's a lot of people that every time they drive, every time they finish a meal, really kind of pushing the conversation to start understanding those little nuances. When it comes to helping them create a plan and helping them to move forward in the quitting process, these conversations and knowing these triggers for them and these behaviors are going to make a big difference in kind of helping push them forward. The other big thing to highlight is previous quit attempts, relapses. What are the circumstances around those events? Why weren't they as successful? Or what things did you try that did really help? And then, of course, there is the issue of mental health and substance use. Individuals with mental health disorders do have higher rates of smoking. Individuals who are substance abusers do have higher rates of smoking. And that's something to keep in mind, but it's also important to understand that you might have to do additional referrals. If you have someone who does have, especially an unchecked mental health issue, you're going to need to focus on the bigger picture and do interventions with that alongside the cessation. So just really, it's about developing that bigger picture and seeing what's going on in the patient's life. Okay. So this is just an example of an assessment. This is called the Fagerstrom test for nicotine dependence. There's one for cigarettes, and then there's also one for smokeless tobacco. And this is just kind of one of those quick and easy assessments to give a patient to really kind of pinpoint how big of an issue is their dependence. It just covers some really basic questions that help kind of define where that patient is. So the first question is a really important one. How soon after you wake up do you smoke your first cigarette? There's a big difference between somebody who, you know, they go half the day and then they're just smoking casually on a lunch break with their friends, or the person who rolls over as soon as they wake up, takes a cigarette off the nightstand, and they're smoking before they even have a step out of their bed. So kind of identifying who those individuals are and where they are. This is just one example of something that you can use to kind of help put them, not to say categorize them, but, you know, to put them in a, to see where they're at, I guess is the best way to say it. So the quitting process, it of course is very difficult. It is an addiction, and it's something that is everywhere. You can go to any convenience store or grocery store and you can buy cigarettes or snuff or vaping, which is also gaining popularity. It's a difficult thing to kick. Only 7.5% are successful during a quit attempt. Most people, it says on average 7 to 10 quit attempts, but if you're going to run into patients who are on 20, 25, 30 quit attempts throughout their life, and that's not uncommon. A third of them are going to relapse within the first couple of days, within 72 hours. That's not uncommon. That's just the reality of the addiction and working through it. So when you sit down with a patient and they're feeling like they're ready to go and you're working on that process and what it's going to look like for them, the biggest thing is setting a date. And this will just be up to the patient. Something, it could have significance like my daughter's birthday, or you know, if it's better to quit on a Monday versus quitting over a weekend. On average, actually quitting at the beginning of the week does work out better for individuals. So a lot of people like that Monday, Tuesday quit date. But again, it's just up to the patient. Environmental changes. So we're talking about throw away all of your paraphernalia. It's going to be really hard to quit when you still have a pack of cigarettes in your purse, your ashtrays are all over your house, your car has a distinct odor. All of those different things are going to make it harder. So encouraging them to, when that quit date comes, all the paraphernalia, your lighters, your cigarettes, everything has got to go. If you can clean the fabrics in your car or your drapes or whatever it is that has that strong smell, and getting rid of that, it does help to create the atmosphere that is a little more conducive to quitting. Deciding on nicotine replacement therapy options. There's, of course, the basic, the patch, lodge, and all of that. There's actual prescription medications. We'll go into a little more in depth on that in a minute. That discussion around the triggers and what we just talked about in the last slide, that will kind of transition into withdrawal symptoms and craving. So if we can understand what that looks like for the patient, we'll be able to create a more targeted plan around those symptoms, around what causes those cravings, and help to prevent them and help to create a plan to work through them when they do occur. And then developing a support system. Friends, neighbors, church, wherever they may come from, just finding people that will support them through this journey, people that they can call or reach out to when the cravings feel like they're overwhelming. And it could also be that people don't have a good support system. If someone is trying to quit, but maybe her husband and 3 adult kids all live at home and they all smoke and none of them want to quit, that's going to create a very difficult environment. So understanding what the support looks like for that person. Some general withdrawal symptoms. This is good to be able to share with your patients so they understand what they're up against, really. Not every person is going to experience every one of these, but at least they'll kind of have an idea, okay, if this happens, if I start to feel anxious or nauseous, if I start to get fidgety or angry or irritable, I understand that that's because I'm trying to quit. I understand it's just a symptom of that. And I also understand that it is going to go away. So just taking that few minutes to go over these symptoms with a patient and really give them that heads up and helping them to identify, what has occurred to them. A lot of people have already had quit attempts. They've already experienced some of these symptoms and they know. So helping them pinpoint, okay, you felt this last time. What are we going to do about it this time to help you cope better? And that's the same exact thing, the same exact principle when talking about possible triggers. Some of these are pattern triggers. So again, driving, meals, talking on the phone, those things that are just, very almost subconscious. I do this and I have a cigarette in my hand and that's just how it is. So just have them list the triggers that they know and help to create a plan to combat those triggers. Promote the changing of those activities. So maybe before, when you were driving, take a different route, maybe, just actually try to physically change what you're doing so that you don't have that immediate response. You don't have that immediate habit taking over. So take a different route, take a few different roads on your way to work. If you have one before or after a meal, I don't recommend substituting with candy or something like that, but maybe, a lozenge or a sugar-free hard candy, something like that to replace that. Just, again, let the patient decide this is my trigger and then help them come up with that replacement behavior. Okay, and this is just kind of touching on what I was just going over, those alternative behaviors, avoiding environmental triggers. If somebody goes to the same convenience store to buy their cigarettes every other day, encourage them to go to a different location, a different store, a different gas station, so that they're not constantly bombarded with those cigarette ads everywhere. And they walk in and the clerk has their pack already on the counter for them when they walk in the door because they're regular. Things like that to just avoid. If there is, again, those issues of mental health or similar kind of concerns, it may, again, require additional referral or additional support along that line. Development of coping skills to deal with extreme stress or trauma or whatever it may be, that may need to coincide with the process of quitting. But in general, just giving basic coping skills, things to help them out is definitely, it's a big difference and it helps patients. And overall, just do everything you can to keep with that strength-based intervention, everything being patient-centered. It's a big difference between, working through things like this as opposed to, don't you know how bad this is for you? Don't you understand that, you're going to give your kid asthma or you're going to do this or your skin looks terrible? Avoiding all of that side of it and just really focusing on, quitting is hard, but you know what? It was really hard for you when you were transitioning to your new job last year and you did awesome at that and you're going to do awesome at this. Just keep that focus on the positive. They get enough negative, you know, in the media and everywhere else, so. If you are able to actually sit down and focus on a solid plan, you're going to want to, again, look at those quit attempts, what worked, what didn't. That really paints an amazing picture of what could work for the patient. If you have someone that says, yes, I tried to quit 12 times and I used the patch every single time, well, maybe don't look at the patch this time. Let's switch it up. That didn't work for you before, so let's try something that might work now. Let's change some things. Again, focus on the nicotine replacement therapy, what's going to be appropriate, what have they tried, what haven't they tried, and creating that list of coping mechanisms and alternative behaviors to deal with withdrawal and cravings as it occurs. It's really everything that we talked about and just putting it in one specific place at one specific time to give them a plan to take with them. I'm not going to go very in depth with nicotine replacement therapy. I know that I'm sure all of you are familiar with the different therapies and kind of understand what they are and how they work. I do have a lot of handouts and things that I'm going to attach to the follow-up, and I do have a simple guide to the different NRTs that you can use as a reference if you'd like, that has dosing recommendations, the pros and cons to each, and just general notes on their usage. So I do have that available to you. That will go out. Just in general, the whole purpose of the NRT is to substitute for the smoking, for whatever nicotine tobacco product they're using, but keeping in mind that it's not going to mimic that positive smoking effect. They're not going to put on a patch and get that high 10 seconds later like they do with a hit from a cigarette. It's just to really help even out the bad effects. It's to help minimize the withdrawal and the cravings so that they can get through that process. But that is something to keep in mind when you talk to patients. I think there are people that feel like it's not working, it's not helping them because their expectation is that it's going to feel like they're smoking. And so we need to make sure that they understand that that's not the case. It's just going to help you have an even keel. You're not going to get the sort of high from your tobacco though. So I will just say with the nicotine replacement, there is more evidence coming out that it is really good to kind of mix and match specifically with a long acting and a short acting. So the long acting, which you can see here, are the patches and then the actual prescriptions, the Chantix and the Zyban. They're going to help kind of put someone at an even space throughout the day. And then having the addition of a short acting NRT, which will be our lozenge and gum, the inhaler, and the nasal spray to help get through those intense cravings. So it's essentially just going to give them that little bump to help get them through a difficult time during the day. It was, I don't know if you know, any of you used to hear the negative connotations about nicotine replacement. If you know you have one, or you know you have too much, you're going to get really sick. You could have a heart attack. There was a lot of negative connotation around them for a while, and then there was a lot of just myths, things that weren't even true. But it is safe. You can combine these therapies. It is okay. Of course, making sure that the patient is physically healthy. You want to make sure the doctor understands the regimen and clears them. But it is okay to do this mix and match as long as it gets to the patient and gets them in a space that they can overcome those difficult cravings and get through that it'll work out fine. Typically, the worst thing that does happen is they have a patch and then they start smoking. Nausea is going to be that first indicator that they have had, they're overdoing it. But normally that's a negative reinforcer, and so people are just going to stop. They're not going to have another cigarette because they're nauseous. So it tends to work out, and that is just something to keep in mind. If you have someone, again, that always only ever used the patch or only ever used whatever else, to mix it up and to know that there are other choices that can be added to. This is just a nice visual for those of you who prefer the picture over me blabbing. It just kind of shows the timeline of withdrawal symptoms. So you see that giant yellow curve, which is going to coincide with someone who quits. The symptoms, the withdrawal symptoms, it's going to peak and then slowly go down. Withdrawal itself typically is a few days, a week at most. It's the cravings, of course, they're going to continue. They're going to still have those cravings. They're still going to have that addiction, but the actual physical withdrawal is not going to last months like the cravings will. And then the bottom there, you see it's that same big spike, the same orange spikes to represent the cravings, but with the green to show you how the NRT can kind of help create a more even playing field for the person as they're quitting. And then those little bumps to show if we have a short acting, that we can help control those serious cravings and keep them from relapsing, hopefully. Just a quick note on relapse prevention. Of course, you want to think of that at the start of the whole process. You don't want to wait until they're in the middle or they've already kind of started to relapse. You just want to go full speed from the beginning and focus on the big picture and focus on how to prevent them from relapsing. And that all just goes directly into the plan that we talked about. Understanding your coping skills, your support symptoms, but also having that conversation of what it means to slip up. The whole process is a really long journey. It's not about success versus failure. It's not, I had a cigarette, so I failed, I'm giving up. It happens. Mistakes happen. Slip-ups happen. So when you talk to someone, remind them that one mistake doesn't have to derail you. It doesn't have to mean that you have failed. It doesn't mean that you give up. It means you put down the cigarette, you walk away, and you keep going with the process. That's another hard thing. You know, patients, they're hard on themselves. They're their worst critics. If they make a mistake, they think that's the end and they think they failed. And just being that cheerleader, no, you didn't fail. Just keep on going. One mistake isn't the be-all, end-all. And a little tidbit on vaping. Of course, we have seen an increase in the use of vaping products, e-cigarettes, all different names, all different shapes and sizes. And there is a lot of back and forth. There are people that, you know, they're proponents of it. They think that it's going to help people quit smoking. There are, you know, people on the other side that feel like it's just as hazardous. The truth is that we truly just don't have that much data. We don't have what we have for cigarettes and for smokeless tobacco. So there's just a lot to be learned. Some of the things that we do have, first of all, adolescents is a huge population for vaping. And just to make note, in Colorado, this problem is major. We have almost twice the youth vaping rates as the average of the rest of the country. So this is something that seriously needs to be dealt with and keep our eye on. It's also been shown that people, especially adolescents who are vaping, are twice as likely to transition into conventional cigarettes. So really, we're looking at what is essentially the gateway into smoking when we have these youth starting with vaping in middle and high school. Currently, there's no actual regulation for these products. So the liquids that come with the vape, there isn't actually regulation on how much nicotine is in there, what chemicals are used. There is just now, the FDA is going to require ingredient lists on these products. I think the bigger companies have started to do that, but the local like ma and pa type shops that sell these kind of equipment, they're not at that point yet, but hopefully soon. And this is a serious thing that we want to see, because there are chemicals, when tests have been run on these liquids, that there has been formaldehyde, for an example, that has been found in them. Also diacetyl, if you've ever heard of popcorn lung, it's a flavoring that's used actually like in popcorn, but the chemical caused serious lung disease in the people that worked at the factory. So that component, that chemical, we're now finding in these vape liquids. They have, you know, and some of them are just sugar water, honestly. So they could be made of anything. There is no regulation at this point. But it still has the nicotine, which again, is the addictive agent. So it's gonna keep you hooked and keep you spending the money and the time. And one more point I do want to make is where it says dual use. Basically, those people who they are smoking cigarettes and then they are kind of transitioning to the vape, thinking that it will help them quit. Most of the time, they don't actually quit. They become a dual user. So then they're just going back and forth between their vape and their cigarettes. Usually, you know, depending on if I'm out in public versus home, whatever it is. These people end up kind of using both products instead of switching solely to one or the other, or using it to quit, which a lot of people do think that they have that intention going in and then it doesn't work out. The last little section is just some resources that I want to share with everyone. I'm sure some of these are the obvious, of course, the quit line. Colorado actually has a really good quit line. The average quit line will spend like $2.15 per patient. Colorado spends double that per patient. So they really do have a lot more involvement, and they do have a lot more resources than other places, which is great. With that said, it's not for everyone. It is a very specific service. It is a telephone service, and you know, it has limitations to it. So it's not going to be the best solution for every patient. I recommend that you don't make it the only resource. It is easy to just, you know, fax in the referral or give them the 1-800 number. But you're going to want to have more available, because if it's just left to that, success might go down a little for certain patients. I also want to point out that the quit line offers NRTs, which is wonderful. And for people who are lower income, you know, this is an amazing way to be able to get those resources. Because if you just go to the store and buy a box of Nicorette, it is expensive. It is more than the cigarettes. That is hard to justify. If you're looking at me and I'm a smoker and I can spend $5 on my cigarettes or $25 on those patches, guess which one I'm going to choose? So it really is a great way to help get them that resource. It also is helpful, like we were talking about those dual use NRTs or having combined therapy. To help save money, we can get our patches from the quit line and we can, you know, use our insurance, or we can just pay out of pocket for the other one and be able to kind of create a plan that uses those therapies in the most fiscally responsible way. So it's great for that. Online services, of course, the basics, smokefree.gov, that's kind of a big one that everyone is used to seeing. I recommend becomeanx.org. They do have very comprehensive information. They also have a really great step-by-step guide. So all of the information that I talked about today, all of the things that we covered, they have a really good like full guidebook for patients to access, and everything is free. And it just gives them those resources. So I do recommend that if you've never checked them out before, to give them a look over. Pathways to Freedom is something that is very specific to the African American population. There is a history of tobacco companies targeting that population, and ads and everything that really focused around that community. So this is a specific guide that is designed for African American individuals that talks about those barriers and talks about those things that they face as a community that have been put in front of them. So if you have any individuals that are African American, that might be a good pamphlet that you can just print out for free. And I have that, I believe, in the resources that I'll send you as well. The other thing, I know it's not an option everywhere, but if it is something that you have locally, an actual in-person support group, if you can get a patient to go, I know that's not easy, trust me, but if you can get a patient to go, they are up to 4 times more likely to actually quit and quit for good when they have that support system. So if it is available, just do your best to recommend it and then let them know that it's there for them. And the last little bit are kind of, you know, our amazing 21st century quit tools. We have apps on our phone, and what you see in this picture is actually a wristband. So think of it like a smartwatch, like we see, or like, you know, one of your pedometer watches that we have now. So it's actually made by Nicorette, the company that makes the patches. They have this wristband that you can get that syncs to your phone, and you push the button every time you have a craving or every time you use your NRT. And so it helps people track all of that information just by like pushing the button whenever they have the craving. I haven't heard of anyone that has used it. I think it's pretty new, but if you have somebody that's super techie, maybe they'll be into it. So just, it exists. And then here on the other side is just a list of popular apps to kind of help people quit, things that they can get for free on their phone. I do have kind of more information about individual ones. If you are inclined, you know, feel free to ask me. But some of these, you know, they're kind of like quit logs, so they just log in, you know, when did they have their last cigarette, when are they having cravings, it can kind of go by that. And then some of them are a little more interesting. They're actually gamifying the quitting process. So if you have like 3 days that you didn't smoke, you're developing these points and you can level up, and it makes an actual kind of game out of it, which I think is interesting, and especially for kind of the younger generation, that might be more appealing, and it might add something positive to this difficult process. So yeah, that's really the end of my spiel. The last bit is just some additional references from the information that I have in this presentation. Are there any specific questions or anything that you would like to add to this discussion? I certainly don't want to talk at you. You guys have amazing experience in the community and with your patients. So if there's tips or tricks that you have come up with, I would absolutely love to hear about some of that. I just wanted to kind of give a general overview of things that, you know, the evidence base, looking at these things, this will help increase success. But the real life stuff that you guys do, I think is just as important, if not more so. So feel free to type in the chat or unmute yourself if you have anything you'd like to add.
And while we're waiting for people to think of their questions, Amy, do you want to say also a few words of how this ties into our lung cancer screening pilot as well, and how this information can be applied to the lung cancer screening?
Yes, absolutely. So a part of that process for getting a lung cancer screening referral is going to involve a shared decision-making visit. And I'm sure this is familiar from some of our past talks. but it's basically going over, the pros and cons of the screen and talking about the patient's values. But part of that also is smoking cessation. If someone has already quit, they're a former smoker, then of course you want to encourage continued abstinence. But for those that are smokers, smoking cessation in some capacity is required as a part of that referral. And I'll be completely honest, the guidelines on that are pretty loosey-goosey. You could literally hand them a flyer and call it smoking cessation. But I'm just here to encourage you to get a little more in depth and to kind of work through some of these processes with the patient as a part of that process. If it's required and you got to do it, you might as well just go big. So just keep that in mind if you do have patients coming through for that referral, that this is a part of that. Okay, did I put everyone to sleep? Is anyone still on the other line? It's so quiet. Okay, well, I shall move on. We're here, thank you. I'm glad you stayed awake through my ramblings. I appreciate you. So I'm gonna go ahead and just, again, I'm gonna send out lots and lots of resources that hopefully you'll be able to utilize in your own clinics, and just tailor everything to your population. I tried to keep everything that I talked about as general as possible, because I know everywhere you go, everyone you meet, it's a different story, it's a different situation, and I just want for you to be able to take these basic ideas and turn it into something that works for you. If ever there's anything kind of more specific that you want to focus on, just let me know and I can get that sent out to you. There is one last thing that I have for today. We have been focusing on our Links of Care survey. And I know that a bunch of you, almost every clinic actually responded to that survey. So first of all, thank you, because that makes a huge difference when we're able to have that information and have that data. So thank you everyone who did fill that out. We do have another branch of that survey that we would like to send out. So we worked with you guys in the amazing clinics and we focused on health departments to see where they're at. But we also want to have a branch that is community organizations. So my request to all of you, if you could just type in the chat or unmute yourself and just give me one or two community organizations that you feel are valuable and that have worked with you and worked with the healthcare system in general. People that we can reach out to understand that bigger picture of community and what healthcare looks like as a community. Oh, thank you, Jill, Community Reach Center. If you could also put just like the city so that I know, because I feel like Community Reach Center, there's probably a few in the state. Thornton, beautiful, thank you. Look, Health Alamosa, awesome.
And if you think you have an idea of one, but you can't think of the name of it at this moment, if you want to follow up in an email to us as well, anytime you are able to share that information, it's super helpful.
I see some coming in. Thanks, guys. We really appreciate it. You know, because I could go ahead and I could do a Google search of community resource centers and things like that, which I've done. But if I can really just, you know, hone in on the people that make a difference in your lives and the work you do, it helps. It really helps us to just find the right people and find the right direction. So thank you so very much. Thank you, Katie and Lisa and Cindy. See your answers here.
And yeah, thank you everyone so much for joining us today, and we'll send you all of these resources and the dates and registration information for our upcoming webinars in our follow-up email. Let us know if you have any questions. We'll stay online for a few more minutes as you keep typing in some questions, but we'll let everyone jump off. So thank you very much.
Thank you all. Have a great rest of your day.
Bye.